and a quiz will be there after the first session. So you can take part in the quiz, and there are first, second, and third prizes also to be won, which will be in the form of a certificate. So I welcome Dr. R.V. Jayakumar sir, our patron, and Dr. K.M. Prasanna sir will be soon joining us. And I welcome our president, Dr. Sarita Bajaj ma'am. And we are now going to start our session for today. For that session, I welcome Dr. Minnie. She'll take over from here, and she is the moderator for today's session.
Thank you very much, Dr. Pramila. So welcome to today's Wednesday Special Edition Thyroid Clinics. And to chair our sessions today, we have Dr. Duggabandu Naik. He is the Additional Professor and Head of Department of Endocrinology at JIPMER, Pondicherry. And he is a very distinguished academic career and spanning 12 years. And he has 50 publications in index journals. And over to you, sir, for conducting today's academic sessions. Thank you.
Good evening, one and all. It's a great pleasure to be a part of this academic fest, and which is going to be held over last 1 or 2 hours. On behalf of Thyroid Endocrine and Thyroid Society, I invite all to this academic fest. To start with, we have 2 speakers in the line. First, I like to invite Satyanath sir, Satyanath Mukhopadhyaya. He is the professor and at IPGMR Calcutta. Sir is a very well-known and prolific speaker, and he has been in the this field for so many years, and he is well-known as a speaker well-known speaker in India. I invite Satyanath sir to deliver his
Thank you.
talk.
It's a pleasure being here. Thank you. Actually, Dr. Dinabandhu, I think the plan is somewhat different. You also invite Dr. Bagish, and he makes a presentation.
Okay,
and then we discuss back and forth, slide by slide.
Perfect. Go ahead, Dr. Naik, please. Just invite Vagish as well.
It is
So
my
Vagish also, yeah.
It is my pleasure to invite Bhogesh Iyer sir. I have known him for a long time, and sir is currently as a professor in St. John's Medical College, Bangalore. And sir is a very well-known speaker to everyone, and a very well-known endocrinologist in the Bangalore. I invite you, sir, for this academy.
Good evening. Thank you, Naik, for your kind introduction. It's a pleasure to be with all the, I think, eminent people in thyroidology from India. It's a pleasure to be with Dr. Satyanath Mukherjee sir. We'll be just having a discussion over a case which I'll be projecting. Is my screen is visible?
Yes, your screen is visible.
Yes,
you just have to make it full screen. That's it.
Okay.
Yeah, slideshow.
Yeah, fine. Okay. This is just a case which came to us in the month of January. Lady from northeastern part of our country. He presented with swelling in the neck from past 3 to 4 years, which was gradually increasing in size from 1 year. Satyanath sir, why it is so common thyroid nodules we are seeing, which it was not seen earlier?
Right. So, leaving aside this particular nodule, let me tell you that a recent study has shown that the increasing incidence of thyroid nodules is associated with an increase in the density of endocrinologists in that particular area. So the number of endocrinologists appears to be a risk factor for growing incidence of thyroid nodules. And one might surmise if reducing the concentration of endocrinologists might be an intervention to reduce the incidence of thyroid nodules. That's in a lighter vein. But then when you have more endocrinologists, you screen people more for nodules, you end up picking up nodules that are small. And if you have a malignancy in those nodules, Mostly they are papillary microcarcinomas that do not affect morbidity, mortality, or quality of life in a significant way. So maybe the large majority of those nodules can be left alone. But the issue you have presented here with this particular lady is that a swelling which is visible, that's why she presented to you, and this is gradually increasing in size. So this is bad news and needs further evaluation. So maybe will you go to the next slide, or shall we?
Yeah, next slide.
Fine. Yeah, so this is increasing. Status appears to be euthyroid, but we would still like to have a serum TSH at the baseline. No obstructive symptoms. I assume that the overlying skin is also not showing any features of inflammation. Now, again, family history is significant in that the mother died at the age of 35 years due to papillary thyroid carcinoma. Again, would be rather unusual for papillary carcinoma causing death at the age of 35. So maybe a very skewed kind of presentation, maybe a very rare family. And then to make matters more complicated, the nephew had medullary thyroid carcinoma operated. So maybe now it's your turn to tell the story further, Bhagesh.
I feel any nodule we notice, it is better to ask for symptoms of hyperthyroidism and hypothyroidism in the order of benignity. If somebody has a nodule with a hyperthyroidism, it's slightly more relieved than somebody has got a hypothyroidism or a euthyroidism, because the possibility of having a serious problem with hyperthyroidism and a nodule is less likely, but more so we see with the euthyroidism or a hypothyroidism. I think there is one analysis they did. TSH acts like a growth factor for the nodule. So they found, when a recent study found, if TSH is more than 2.24, the possibility of getting a malignancy in a nodule is on the higher side. So that's why.
Yeah, couldn't agree more. Only thing is, since I'm not presenting my set of slides, otherwise I could have shown you. Only 2 weeks back, we came across a lady with a presentation like Graves' disease. TSH was suppressed, and naturally that called for a technetium thyroid scan, and there was a cold nodule amidst increased uptake. So if you have a cold nodule in presence of increased uptake in the rest of the thyroid, the likelihood of malignancy is a little more, and FNA actually confirmed papillary thyroid carcinoma in that lady.
Yeah, I think it is known as a Marine-Lenhardt syndrome. It's diffusely uptake with a cold nodule, and the chance of malignancy is quite bad. Yes. So the swelling is not very big. That's why this patient doesn't have any obstructive symptoms. But if patient has got obstructive symptoms, then it's again tells that it's quite big and it's invasive also. We don't know till we examine thing. So that again adds to the problem. And
yeah, right. Sorry to interrupt you. My only concern is that this is gradually increasing over 1 year.
Yeah.
So yes, again, it's your call now, please.
Yeah. So, but now everything is a genetic. We are getting genes in everything. So family history makes very, very important, especially when it comes to the papillary thyroid carcinoma, and very much true with even a medullary thyroid carcinoma. I feel that the mother died at the age of 35 years, probably much 20 or 25 years back. We don't know the cytopathology status during those days. Now, definitely in the past 1 or 2 decades, we have improved in leaps and bounds with the histopathology of the thyroid nodule, and FNAC has made it much more easier and precisely diagnose the cytology, thyroid cytology. We don't know what was the death, because 35 years papillary thyroid carcinoma has to be very aggressive or something else it must be. Yeah, I feel, but it was given by the mother. That's why given by the patient. That's why you took it as a papillary thyroid. There was no confirmation from any of the records, but she was very sure that nephew had a medullary thyroid carcinoma. That she was very much sure. So this takes us to a very strong thing. Probably we are dealing with much more serious problem in this young lady with a strong family history of thyroid malignancy in the past.
Right. And as far as this medullary thyroid cancer is concerned, again, I would like to tell the audience that if you do an FNA on a nodule that turns out to be medullary thyroid cancer, most of the time, the diagnosis will come as a follicular neoplasm. They not even tell you that this could be medullary thyroid cancer. So then the question comes whether you bring in serum calcitonin assay as a routine investigation in the workup of thyroid nodule. But I think considering the availability of this assay, the cost, nodules that turn out to be papillary thyroid carcinoma, nodules that are not associated with systemic features, like, MTC classically presents with a very small neck mass, pea-sized nodule or thereabouts with diarrhea. That's the classic presentation. So if you don't have any of those features, maybe we can make use of calcitonin in a restricted way.
Yeah, I very much agree.
Yeah.
I very much agree with you, sir. Even we are not routinely doing calcitonin in a nodule evaluation. Mainly availability of the assay and also cost is a major barrier to recommend it or do it routinely in our center.
Absolutely. And calcitonin can also be falsely high. There are several causes. And nowadays they say in some of the Western centers that you measure monomeric calcitonin, which is specific for MTC, but the assay is not available in India at this point of time.
I think even chronic autoimmune thyroiditis itself can increase the calcitonin levels, and wrongly sometimes we may label them better the MTCN.
Absolutely. And then coexistent CKD, maybe some gastrointestinal diseases also. Right. Yeah. Please.
So with this history, I think we proceeded to the examination. Patient had vitals were stable. She was otherwise normal. She had 2 by 2 centimeters swelling on the right side of the neck, which was firming consistently, and it was moving with the deglutition. Otherwise, there was no other features, nothing. Even a ENT evaluation was done. It was normal. There was nothing, no change in the voice or even a vocal cord or a drooling of the saliva on any of the side was not noticed.
Right. So obviously this nodule, I mean, once you have demonstrated that the TSH level is normal or maybe even high, but certainly not suppressed, the next plan would be to do a high resolution ultrasonography.
Yes. So in our center, I think biochemistry is done much easier than the ultrasound. Ultrasound, we do need to take an appointment, but for the biochemical test, it's most of the time gets done much more easier than the ultrasound.
So Bhagesh, can I interrupt you here? And
Yes,
I would like to pass on a message to the residents who are going to become practicing endocrinologists. Thyroid ultrasonography is something which should be done in the endocrinologist's office. Many of us have been trained by the American Endocrine Society, and we are certified in doing thyroid ultrasonography. So I would like to encourage the residents and maybe some of the research fellows to get themselves trained and have an ultrasound machine installed in your office. Because what happens with the radiologists is that most of the time they're looking at gallbladder stone, and you ask them to look at a thyroid nodule or a parathyroid nodule, that becomes a huge challenge for them. And they also cannot provide enough time to interrogate the nodule in a way that we would like them to do. So it's always better that you do ultrasonography in your own office.
I think
go ahead, please.
It's really true. It is in the West, they do ultrasound and also they do a FNAC by themselves, endocrinologists. In fact, only the slides are sent for the confirmation to the pathologist. Otherwise, I think if we attend any of the endocrine conferences, there is at least a day is kept for the training. So I encourage, as you are told, I think if an opportunity is there, I think everyone should undergo that training. It helps us, and definitely we can review at least images with some amount of a certainty when we get the ultrasound report if we don't have a machine installed in our office.
Yes, Vagish, may I again suggest that in the next ITS, next conference, the organizers can have a workshop on thyroid ultrasonography and FNA also, like they do in the Endo Society. We have all been trained in not only sonography, but also how to do an FNA, send the slide, and then send it across to the pathologist.
Excellent suggestion, Satyanath. Thank you. That is, thank you very much. Yeah.
So,
Dr. Sarita, we did that for Endocrine Society ACCon a couple of times. In Kolkata, I distinctly remember we had 4 ultrasound machines installed, and we got some of the DM trainees trained in thyroid ultrasonography.
Absolutely. That is in the planning, and now that you've emphasized it, I think it makes it all the more important and relevant as well. Thank you. Please continue. Sorry for the interruption.
Pleasure.
So I think investigations of these patients are here. The only here because we got, otherwise routinely we won't get a calcitonin and a nodule evaluation. The reason for getting calcitonin in this patient, because there is a family history of a MTC. Maybe you had an MTC, that's the reason calcitonin was also done in this patient. TSH is normal, calcitonin levels are on the higher side, 1900. Calcium is also on the upper limit of the normal. Our lab assay is 9 to 11. But anyway, if you take the standard thing, it is upper limit of the normal. Phosphorus is little lower. PTH is normal. And calcium creatinine ratio was done in view of a calcium, which was on the higher side. It is also little 0.25. And urinary metanephrines and the prolactin was done because young patient nodule with the calcitonin on the higher side and also family history of a MTC. I think these were the biochemical evaluation which we carried out. Anything, sir, on this?
So assuming that this calcium level of 10.9 is normal, and you say that PTH is normal, then your metanephrines are normal. So I think this effectively rules out MEN related MTC, right?
Yes.
So this could be only familial MTC given the family history, or it could be a sporadic MTC. Just now we were discussing a little while ago that calcitonin should not be routine, but here in this situation, large nodule increasing in size. Again, large nodule is rather an atypical presentation for MTC. So many odd features, but then large nodule growing in size and high calcitonin with a positive family history of MTC. Well, I think you were there. You got it. MTC, right?
Then we did ultrasound of the thyroid. I think this is the ultrasound of the patient. You can see the right side. These are the strap muscles. What I'm moving my cursor. This is the nodule, which is almost replacing the right side. It's quite heterogeneous. And even the margins are not very clearly visible. We are not seeing any halo surrounding the things. And also the grading, what we got was thyroids 5. So same, I think. And there was one more nodule on the left side. And there was some doubt regarding the lymph nodes or a parathyroid. They were not very sure, and we couldn't be convinced with the images also on. So how important is the ultrasound in the evaluation of the thyroid nodule, sir?
Yeah, absolutely, 100%. Unless the TSH is suppressed, you have to do ultrasonography first. And when we were students, and that was more than maybe 3 decades ago, the thyroid nodules, the investigations used to start with radionuclide imaging and then blind FNA. So we have moved away from that approach, and now it's always, USG, provided you have been able to show that the TSH is not suppressed. TSH normal or high, your next investigation is USG, and you have the finest details worked out here. except that lymph nodes, I cannot really delineate them in this picture. So had I been able to see them, I would then have liked to see whether those lymph nodes are reactive in nature sonologically, or they represent potential metastasis, because MTC is notoriously known for lymph node metastasis, and that would have changed the classification also. But then ultimately we have to take this nodule out, and then the histopathology would tell us further.
I think before moving, you emphasized greatly that ultrasound, we should emphasize training, the training module of our conferences and also our students. I think just I like to take them through a little ultrasound features of a thyroid. I think this is a transverse picture of the thyroid, wherein we have got a strap muscles, and also we are comparing the nodule, comparing the thyroid texture. We generally compare the strap muscles or with the rest of the thyroid thing.
Bhagesh, sorry, I think this is a zoomed in view of a normal looking thyroid. I don't see the nodule here. The strap muscles are enlarged and they look like nodules. That's what I find here. This is a normal thyroid, and you should not give it in the exam like they do in the membership exam, that MRCP, a normal thyroid. So this is normal thyroid.
Yes.
Okay, right. So let's go back. Yeah.
Next, I think these are the features which we should look for sonographically. Size of each lobe, what is the echogenicity? We can have a normal echogenicity, hypo or a hyper. Hypo echogenicity is the one which is of a more importance. It tells probably we are dealing with a malignant nodule rather than a benign nodule. Vascularity, and is it causing any pressure on the airways? That's a tracheal deviation. And also isthmus thickness we need to see. When it comes to the nodule size, location, echogenicity, composition, echogenic foci, margins, whether they are irregular or infiltrating is an important. Even the vascular pattern within the nodule also gives the what is the underlying pathology of the nodule. Lymph nodes, if it is visible, I think same thing again, size, shape, calcification, location, vascular pattern, and echogenicity, we need to look into it. Just I will take you to, yes.
And loss of hilum.
Yeah, hilum, yes.
Yeah.
So, yeah. I think these are the different nodules which have been shown. I think we can clearly see one nodule here, which has got almost same echogenicity as a thyroid. Almost we can call it as an isoechoic. So this isoechoic by and large suggests normalcy or a benign. When it is hypoechoic compared to the other things, when it is hypoechoic, then it needs to be malignant. And also the cyst, you can see it is a cystic one. By and large, all cystic nodules will be benign unless you see some amount of a echogenic material within the cyst. Anything else, sir?
Yeah, if I may add very quickly, if we recapitulate the features that characterize nodules, so you look at the margin, if it is regular, irregular, and then isoechoic, hypoechoic, you have already mentioned. Then the presence of halo is debated, but if you have a complete halo, it's good, and then no microcalcification. But then vascular pattern, unlike ATA or AC guideline, the National Cancer Network in the US, they say they don't attach much importance to the vascularity. So there is a difference there, but those are the features that actually characterize or differentiate a benign from a potentially malignant nodule. On the right panel, which is B, right upward, so yeah, hypoechoic, but the nodule also has irregular margin.
Yes.
So that makes it look more sinister. There are specks of calcification, no halo, and then maybe if such a nodule is vascular and hypervascular and has associated malignant lymph nodes, that would even increase the possibility of a malignancy. Further, now coming to the panel C, this simple cyst, it looks like a simple cyst, but there are specks of colloid within. So I think even this nodule would demand an FNA, but if you have a clear simple cyst, that is one situation where you need not even go for an FNA. So, and with the growing use of ultrasound, you were left with a large number of thyroid incidentalomas. So again, you have to have a plan in place to decide which nodules to interrogate with FNA and which nodules not to. So that I think is important. Avoiding unnecessary FNAs. Please.
So yeah, you did mention about the margins. So I think these are the nodules with different margins. Here we can see that irregular margin and also infiltrating into the adjacent tissues definitely looks sinister. Here we can't clearly make out the margin. It's almost invaded to the adjacent tissues. In the C panel C, that lower one, I think to some extent we can make out the halo surrounding the nodule. Probably among the three images what we have got here, A, B, and C, C probably looks closer to the benign, but A and B definitely looks sinister.
Yeah, Bagish, if I may just add here, if you have a peripherally located nodule with not a large ream of thyroid tissue between the skin and the nodule, then you can also apply elastography effectively to interrogate those nodules, and they help us in further characterizing the follicular neoplasm groups.
And one more thing you told, sir, is regarding the calcification.
Yeah.
These are the different types of calcification what we can see in a nodule. The panel A is a macro calcification. The panel B is almost nodule is surrounded by the calcification with some amount of a disruption in between. If it is completely surrounded, we call it as a eggshell calcification. This macro calcification and the eggshell calcification are indicators of a benign problems. But if there is any break in the eggshell calcification, again it becomes an abnormality. We need to see with a lot of suspicion. And this is the most important. We have one cystic nodule, and the colloid is giving typical of a comet tail appearance. I think everywhere we see this, one of the fancy name in the thyroid ultrasonograph is a comet tail. Will you elaborate on this, sir?
Yeah, so comet tail is classical, and this is this signifies presence of colloid. The points I would like to mention here is that if you have a mixed nodule, then you classify the nodule in terms of its diameter, concentrating only on the solid component. So you measure the dimension of the solid component, leaving aside the cystic component. And as far as my calcifications are concerned, this micro and macro, they are actually not separated by the diameters of the individual specks of calcium. If you have a macro calcification, like you see in gallbladder stone, you get a negative acoustic shadow, which is very nicely seen here on panel A.
Yes.
Behind the speck of calcium, you have the negative acoustic shadow. That tells you that this is a macro calcification, unlike panel D, where you see micro calcification and no negative acoustic shadows. So that's how you differentiate. Yeah. Please go ahead.
Yeah, fine. I think micro calcification earlier, I think 1 mm was the border between the macro and the micro. Now no longer that holds good in most of the studies.
Yes,
so
as I said, Bagish, actually, if they are 1 millimeter or less in diameter, they wouldn't cast a negative acoustic shadow. Right? Okay.
Yes. I think microcalcification signifies need for an FNAC and to look for the pathology. I think among the macro and the micro is a sinister problem. We need to look into the nodule more carefully.
Absolutely.
Yeah.
Yes.
So next, I think these are sometimes the confusing type of ultrasound images we do get, sir.
So A and B, they look like, I think this is diffuse involvement, But I think this is autoimmune thyroiditis, the classical Swiss cheese appearance. Again, there are fancy names. Some call it a zebra pattern on ultrasound. Some call it a giraffe pattern. I don't know. Maybe zebra would be more like it, but the classical Swiss cheese appearance. You don't need to FNA these.
I think some call them also pseudo nodules. They are not true nodules. They are pseudo nodules.
And not to do FNA in this.
Not to do FNA. Yeah, that's the most important message.
Right.
So I think you are emphasizing on lymph nodes. I think lymph node evaluation is also equally important. I think these are some images of lymph node panel A, B, C, D, E, and F. I think.
So A, if you see that's a normal lymph node, absolutely, you can see the clear hilum, shape is maintained. As opposed to that, if we go to panel F, you can see the architecture is distorted. There is no hilum, and if you interrogate that nodule with the Doppler, you will get a pattern like D, which is a hypervascular lymph node and clearly malignant.
And taller than wide is always again a pathognomonic.
Yes, even that one also looks very suspicious,
yes.
Right?
I think these are the additional images because there was a calcium little on the higher side. We had got the images, but what is the role of additional images like a CT, MRI, and sometimes now patients are undergoing lots of PET CTs. I think they have got flooded with a lot of PET CTs and getting incidentalomas and PET CTs.
Again, FDG avid nodules picked up on PET CT done for some other indications, they becomes a cause for concern. And if they're FDG avid, you need to FNA them. So that's another area where we are ending up picking up more and more nodules. Otherwise, CT and MRI, they remain pre-surgical investigations. I think Dr. Amit Agarwal will take us through that. So those are just done before surgery to define the anatomy.
So with this evaluation, I think our patient underwent FNAC. This FNAC report was, in fact, they couldn't, atypical cells and Bethesda 3 they reported. Actually, I couldn't load the things. It is there in the other. I can. It's in fact they couldn't on the FNAC. They couldn't make a diagnosis of a MTC. Just they told it's atypical cells and Bethesda 3. Then patient was subjected to the further.
But actually, a point I would like to make here is that, and I would also like to know from Dr. Agarwal when he makes his presentation, this is one scenario where I might have jumped FNA and gone straight away for surgical excision. A high calcitonin, 2 by 2 centimeter nodule with all malignant features. So why do the FNA? FNA can actually be misleading in this situation unless you go for calcitonin immunoreactivity, which we do in our institute, but it's not available in most centers. So unless you do that, it's not easy to make a diagnosis. And another message is that when you are looking at follicular neoplasm, which are our problems, see, our problems are not with clearly benign and clearly malignant. Is those aus and flaws, all those in-between situations. When you are doing an FNA, if you also make a plan to do a needle tip calcitonin, needle washing, 2 milliliter of normal saline, dip the needle there, study it, and then do a calcitonin, it can really help.
I think with even a ultrasound like BIRADS, how it has, I think, may have taken the CA breast grading. THYRADS has really giving lots of information regarding our thyroid nodule and the malignancy risk. We do get now lots of reports if it is done in the institutes or somebody trained in the thyroid ultrasound with the THYRADS grading. I don't think it's uniformly practiced across the India. So what about your experience, sir?
At our institute, we have a dedicated cytopathologist to whom we send all the FNA samples, and we get the Bethesda.
Yeah.
And in the radiology also, we have fixed some sonologists who routinely would report the thyroids.
So in our institute, most sonologists are able to give a thyroid's scoring, but when we get from the periphery, it becomes difficult. Many a times it won't be mentioned.
Yeah, so what we do is actually we ask the patient to bring the plate, and we try to do the thyroids ourselves just by looking at the nodule.
So
if I may interrupt, we have only 5 more minutes left.
yeah, I think last about the Bethesda system of cytological nodule. I think you did emphasize somebody trained in looking into the thyroid cytology should look into most. I think more and more they look into more and more they become experienced in reporting, and there is a clear-cut malignancy risk and Bethesda grading, Bethesda category grading, whether it's a 1 and 2. By and large, malignancy risk is almost closer to the normal. What we say is less than 3% through 1 and 2. But when it is 5 and 6, we are very clear the malignant risk is very high. Most of the time, we are stuck with the 3 and 4. This is indeterminate nodule is the where lots of problem and lots of our thought gets into it. But there's a clear-cut malignancy risk with each category of Bethesda system of grading. I think it's one of the very good system. It came nearly 10-15 years back. To be precise, 2007 it came into existence, and with that, I think uniformly we are getting Bethesda grading, and the correlation is quite good if it is reported by an experienced cytopathologist.
Yeah, so Bagish, if I may just add very quickly,
Yes,
these 3 and 4 nodules, I mean category 3 and 4, it's here that molecular diagnostics are coming up in a big way. From the FNA sample, you do that, but you would be, I think, happy to know that Professor Shuja Ghosh at our department, he has recently published his data in JCE&M on cell-free DNA, just from the blood sample, and you look for those mutations, the 4 mutations that are associated with malignant potentials of thyroid nodules. And as a fantastic data he has been able to generate, although it still remains a pilot one, and we need bigger studies for validation. But there's a clear signal that you can tease out clearly benign follicular lesions from clearly malignant follicular lesions with high positive predictive value and high negative predictive value. Because the recommendations say that if you're using molecular diagnostics, then to rule in a malignancy, you have to have a positive predictive value exceeding 96%, which is what FNA is supposed to provide you. So your molecular data should be able to match the FNA expectations. And similarly, for a clearly benign nodule, you have to demonstrate a high negative predictive value to the extent of 98%, which is what FNA provides you for a clearly benign nodule. And Dr. Ghosh's team, actually, they were able to achieve those kinds of predictive values in the benign and malignant nodules.
Yeah, I think we have gone through that. You were also part of the author in that paper, and it was editorial was written by Eric Alexander from Boston. I think that's right. Really a credit to all Indians.
Yeah, but I was not one of the co-authors. There is another Mukhopadhyay in the department, Pradeep, who was a co-author.
Okay.
Right, yeah.
I think with this, I think patient underwent a surgery. Surgery was quite uneventful, and this was a cellular neoplasm in the spindle cell, and a final report came as an MTCN.
Right.
Yeah, I think here we rest our case discussion and the duology. I think we are almost there at 8:40.
So 30 seconds.
Yes.
Again, my final message would be that even for a low suspicion nodule, if you have a good thyroid surgeon, dedicated thyroid surgeon, so I would again prefer total thyroidectomy, because the surgeon can ensure that will not damage the recumbent nerve, will not take out the parathyroids. A good thyroid and parathyroid surgeon or an endocrine surgeon for the matter would actually be able to differentiate parathyroids from thyroid, and so can preserve the parathyroids. So if you have a surgeon like Dr. Amit Agarwal, so I think your recommendation would be most of the time for a total thyroidectomy, because that would help us in post-operative evaluation and management also in terms of thyroglobulin levels and the radionuclide uptake of the residuals. So with that, I think I will stop. And again, Bhagesh, final comments from you.
I think most important, we have in the duology, what I have learned is more and more nodules we are detecting because more and more imaging and more endocrinologists are available. We need to focus on the ultrasound learning from our residents and also all endocrinologists. FNAC should be reported by an cytopathologist who has got a expertise in the field of thyroid cytopathology. And genetics is an exciting, cytogenetics is an exciting field, and there is at least one big leap forward from the SSKM Institute, cell-free DNA in the blood. Without doing even an FNAC, we are able to get some information about the malignancy. I think it's really a step forward in diagnosing these malignant nodules.
So thank you. I think we have come to the end of this duologue or whatever. So maybe it's time to
Thank you very much.
Yeah, thank you.
I really enjoyed that. Thank you, Bhagesh and Satynath. You really worked hard at that. And I think the output has been very interesting. Thank you. Over to you, Naik, Dr. Naik.
I like to thank both the speaker, Bhagesh sir and Satynath sir, for such a wonderful discussion on various aspects of thyroid nodule, from clinical aspect to interpretation of radiology and molecular aspect. And also saying that there's need of a dedicated cytologist and need for training for the endocrinologist, particularly postgraduate. That's a wonderful thing. I think there's a question. One question is there. I think we have already discussed, but I can actually, this question is from A.K. Badiarsina sir from Katak. Sir is asking MEN to be kept in mind or not. I think you have already discussed, but I think you can.
Yeah, it has already been discussed, Anuj. So obviously MEN was kept in mind and it was excluded. Normal urinary metanephrines, normal calcium, normal PTH, that effectively ruled out MEN in this situation. Thank you.
Thank you.
Prolactin was normal.
Yeah. And prolactin was also normal, right? Yeah.
I like to go over to Dr. Mini for the next session.
Yes, sir. So we had a very wonderful and productive first session. Now over to Dr. Gagan Priya for the next session. She is Senior Consultant Endocrinologist, Fortis Hospital, Mohali. And the next session is probably the most exciting session, the quiz round. Over to you, Dr. Gagan Priya.
Thank you. Thank you so much, Dr. Mini. And sincere thanks to the team of Endocrine Society of the Indian Thyroid Society. It's been a pleasure listening to the first dialogue. And I hope the quiz is as interesting and exciting as the dialogue was. So what we'll do over the next 15 minutes is run through 16 MCQ-based questions. And before I start screen share, I would request all the participants to please change your name to your full name so that we can actually identify the winners at the end. We have prizes in the forms of certificates from ITS for all our winners. The second thing, we would be running a poll for you to answer on. So for those people who are on their laptop, you can, just move the poll with your cursor, poll window to one side and keep the screen on at the other end. And for those who are on their mobile, you can minimize the screen and the poll as you go about. So we will go through 16 questions, one after the other. And of course, the answers will be discussed later on at the end of the second session. And I would request you to take about 20 to 30 seconds for each question to answer on the poll. So I hope everybody is ready for the quiz. They're a mix of, different variety of questions, not very difficult. So the first question is very relevant from the point of the history of thyroid. Where was the first ever successful prospective large-scale experiment on the role of salt iodization for the prevention of goiter conducted anywhere in the world? Was it Nubra Valley, India, Lothbrunner Valley, Switzerland, Kangra Valley, India, or Michigan, USA?
The timer will be set for 30 seconds from after this question is completed.
Yeah, the question is done, so we can start the timer now.
Yes, the poll has been launched. You can answer the first question.
So you can see the poll on your screen. So you can just answer. And once you are done, then minimize the poll so that you can see the screen as we go along.
I request all participants to please answer each question separately, because the basis of that question is going to be on the screen, the case or the images. 4 seconds to go. Ma'am, we can move to the next question.
Yes, thank you. So the second question is an image. How is this related to thyroid? Is it a cartoon character with goiter, an eye sign and thyrotoxicosis, a sign in thyroid cancer, or a cartoon drawn by Edward C. Kendall, who was the first person to find the crystalline structure of thyroxine?
Second question started. Fifteen seconds to go. Five seconds to go.
All right. So please do not press submit right now. You will be submitting at the end together. Question number 3, before the availability of thyroid hormone assays, what was the first parameter used to assess the clinical response and adequacy of thyroid hormone replacement therapy? Was it serum protein bound iodine, basal metabolic rate, body weight, or total cholesterol?
Timer on for third question. Fifteen seconds to go. Five seconds to go. Next question.
Yeah. So our next question is, in patients with hypothyroidism, a polymorphism in which of these genes indicates that they are likely to benefit from addition of T3 to ongoing levothyroxine therapy, LT4 therapy? So we know there are blanket, we don't use T3, T4 combinations, but there are certain conditions in which we can consider them. Is it a polymorphism in the T3 receptor, TSH receptor, type 1 deiodinase gene, or type 2 deiodinase gene?
Timer for fourth question on.
All of the questions have one right answer only.
Fifteen seconds to go. We can move to next question.
Yes. So our Next question is, the history is here on the screen, not on your poll options. So you have a 22-year lady. She was diagnosed with Graves' disease 2 months back, has been on carbimazole 30 milligrams a day. She presents now with history of abdominal cramps, vomiting and diarrhea for 2 days. She has a family history of type 1 diabetes and brother. On examination, she has dehydration, cachexia, tachycardia, slight hypotension, grade 2 diffuse goiter, no bruit. On the labs, she has a sodium of 130, potassium 5.5, creatinine 1.6 milligrams PL. T3, T4 seems to be settling in from the last visit, TSH of 0.02. So what is the most likely diagnosis? Is it acute gastroenteritis, type 1 diabetes, adrenal insufficiency, or drug intolerance?
Timer for 5th question on. Fifteen seconds to go. Five seconds to go.
All right, so I'll move to the next question. Which of the following is incorrect? The keyword being is incorrect regarding physiological alterations in thyroid functions during pregnancy. Total T4 rises progressively in second trimester to approximately 1.5 times the non-pregnant range. The downward shift in the upper reference range for TSH during first trimester is typically not seen in the first 7 weeks of pregnancy. Free T4 when measured by commercially available immunoassays is reduced in third trimester. Free T4 when measured by commercially available immunoassays is more reliable than total T4 during pregnancy. Your timer starts now.
Fifteen seconds to go. Five seconds to go.
All right, so next question, please look at the screen carefully because this is a pictorial based question. So we have a 31-year lady. She has a history of occasional rectal bleed and swollen hard gums. She has multiple papules, as you can see on the nose, and you can also see it on the gingival mucosa, buccal mucosa, and over the tongue. She has hematomas on the spleen. Biopsy of these lesions shows non-inflammatory epithelial hyperplasia. A colonoscopy was done for rectal bleed. She has multiple intestinal lymphoid polyps. Thyroid ultrasound shows goiter with multiple nodules. From the largest nodule, an FNAC showed follicular neoplasm. She has a family history of follicular thyroid cancer in mother. So what is the likely diagnosis? Is it Carney's complex, Gardner syndrome, Cowden syndrome, or Werner syndrome? Your timer is on.
Louder. 15 seconds to go. Five seconds to go.
All right, now to an easy question. What is this sign called? Is it Mebius sign, Dalrymple sign, Geoffroy sign, or Van Graaff sign? Timer is on already.
$15 seconds to go. Five seconds to go.
All right. So the next question, again, a case. 65-year lady, she has a history of anxiety for which she underwent thyroid functions. TSH is 0.09. Free T4 is 1.6 nanogram per DL and total T3 is 150 nanogram per DL. She has hypertension, well controlled on medications. She has history of osteopenia, which was detected 3 years back. She's taking calcium, vitamin D, now has osteoporosis, but no history of fractures or cardiac disease. So the question is, what is the next best approach in this lady? Do we leave her on active surveillance with repeat thyroid functions, do a thyroid scintigraphy, give her bisphosphonates or beta blockers?
The timer is on for question 9. Fifteen seconds to go. Five seconds to go.
Recording in progress.
All right, so we're moving to question number 10, another case scenario. 45-year male recently diagnosed Graves' disease. He was started on carbimazole 20 milligrams a day. After 1 month, he complains of lightheadedness and increased appetite. Thyroid functions are improving, but there's a report of random blood glucose during such lightheadedness of 55 milligram per dl. Serum insulin elevated, C-peptide elevated. There is a history of diabetes in his wife. She is taking glibenclamide and metformin fixed dose combination. So what is the most likely diagnosis? Autoimmune polyglandular syndrome 1, surreptitious sulfonylurea intake, Hirata syndrome, or insulinoma. Your timer is on now for question 10.
In seconds to go. Five seconds to go.
Okay, so question 11. What is the Meseberger triad and who described this triad? Tachycardia, exophthalmos, goiter. It was described by Carl Adolf von Basedow. Tachycardia, tremors, exophthalmos, Robert Graves. Goiter, tachycardia and tremors by Caleb Perry, or goiter, tachycardia and thyroid bruit by Meseberger Chekhov. Your timer is on for 30 seconds for this question.
Fifteen seconds to go. Five seconds to go.
All right. So next case is a 36-year lady. She presents with thyrotoxic symptoms. Past history of hypothyroidism since 12 years. She was taking levothyroxine 100 micrograms a day for 12 years. 2 months back, her blood report started showing thyrotoxicosis, so levothyroxine was stopped. After a month, since her thyrotoxicosis persisted, she was put on methimazole by the treating doctor. She insists she has been regular with her medications. On her blood reports, you can see a free T3 and free T4 significantly elevated, a TSH of 0.01, even on methimazole 30 milligrams. A technetium scan was done after discontinuing methimazole for a week. There was no uptake. Thyroid ultrasound is showing a small gland with no nodule or vascularity. Ultrasound abdomen and pelvis was also done, which was normal. What is the most likely diagnosis? Struma overi, painless thyroiditis, factitious thyroiditis, or Graves' disease?
Timer on for question 12. Fifteen seconds to go. Five seconds to go. Next question.
Right. So few quick questions to end the quiz. What is the cutoff of TSH in serum units? So mind you, the word is serum units for recall recommended in the neonatal screening guidelines for congenital hypothyroidism in India. And this is the guideline for India from the Indian Society of Pediatric and Adolescent Endocrinology. TSH of more than 10 in cord blood, more than 20 in postnatal sample drawn at 48 to 72 hours, or TSH of more than 20 in cord blood, more than 10 in postnatal sample, or more than 20 in both cord blood and postnatal sample. And option D is more than 10 in both cord blood and postnatal sample. Your timer starts now.
$15 to go. 5 seconds to go.
All right. So question number 14 is, which of the following drugs is not useful in the management of thyrotoxicosis? Is it cholestyramine, lithium carbonate, dexamethasone, or colsevilum? Your timer is on for question 14.
$15 to go. 5 seconds to go.
All right, so question number 15, you can see an image on the screen of an FNAC from a thyroid nodule. We had a very interesting session here. 1.5 centimeters to 1.1 centimeter right solitary thyroid nodule. What does this FNAC implicate? Is it medullary thyroid cancer, follicular neoplasm, papillary thyroid cancer, or renal thyroiditis?
Timer on for question 15. $15 to go. 5 seconds to go.
Okay, so the last question. A patient was referred for abnormal thyroid functions after a routine lab package. Total T4 and total T3 are significantly low and TSH is normal. There are no clinical signs or symptoms. What is the most likely cause? Is it central hypothyroidism, non-thyroidal illness, TBG deficiency, or thyroglobulin deficiency? Your timer is on and this will be the last question.
$15 to go. 5 seconds to go. We are done with the quiz.
Yeah, thank you so much. And this was the end of the quiz questions. We'll have a look at the answers and the right answers and come back with the list of winners later on at the end of the session. I'll hand back to Dr. Minnie.
Ma'am, there are still people answering. So we have waiting participants.
Yes.
If we can wait for probably about a minute, I think we'll have.
Sure. Yes.
Thank you, Gagan. Thank you. Thank you so much.
Thank you, Dr. Gagan Priya, ma'am. After the next faculty session, we'll be discussing about the answers, ma'am. Then we'll, in the meanwhile, be assessing the responses of the participants and we'll be announcing the winners at the end of the session.
Can we move on to the next session? Because
yes, ma'am.
Yes, please. Yes, Minnie.
Over to you, Naik sir.
Good evening once again to all the faculty and delegates attending this thyroid clinic. The next session is on surgical aspect of management of thyroid nodule. It is again my pleasure to introduce Amit sir. Amit sir is a wonderful speaker and a very outstanding researcher in the field of endocrine surgery. I invite you, sir, for this presentation. Sir is currently working as a professor at SGPGI Lucknow Department of Endocrine Surgery. Welcome you, sir, for your presentation.
Thank you, Dr. Naik. Thank you, Dr. Sarita, Pramila, and Dr. Prasanna Kumar, and Dr. Rajput for a wonderful thyroid clinic. So I'll not bore you with a lot of surgical details. It's a very balanced talk with a lot of endocrinology thrown in. So I must thank Dr. Vagish and Dr. Mukhopadhyay for setting the background. So without much ado, I will talk about thyroid nodules which actually require surgery and involve the endocrine surgeons and the thyroid surgeons. So what is a solitary thyroid nodule? It's a discrete lesion within the thyroid gland that is clinically and sonographically distinct from the surrounding thyroid parenchyma. And I've specially kept this for the postgraduates. You should differentiate between a solitary thyroid nodule and a dominant nodule, because solitary thyroid nodule exists within a normal gland of normal dimensions morphology, whereas a dominant nodule is a thyroid nodule within an enlarged goiter, a diffuse or a multinodular goiter. A lot of thyroid nodules present incidentally during physical examination or during a radiological procedure such as a carotid ultrasound or an XCT. Majority of thyroid nodules are asymptomatic. We must keep that in mind. And they only seek medical attention when they are symptomatic by way of large size. Patients concerned about cosmesis. There's a lymph node present. Patient has compressive symptoms, whether difficulty in eating and drinking or breathing. Change in voice has been noticed by the family members. And most importantly, the patient has an anxiety and fear of harboring a malignancy when he or she notices a thyroid nodule. So the diagnostic challenge for the caregivers, endocrinologists, and endocrine surgeons is to need to exclude the thyroid malignancy and also to exclude hyperfunction. So whether it's an autonomously functioning thyroid nodule or a toxic multinodular goiter. Now, these are the different causes of thyroid nodules. It may be a neoplastic or a non-neoplastic lesion. Neoplastic, the benign lesions, there's a whole list, and most common is the colloid and the follicular lesion. And the malignant lesions, most common being the papillary thyroid cancer, follicular and a medullary thyroid cancer. But we should also keep in mind the various non-neoplastic lesions, which could be a thyroid cyst, a thyroglossal cyst, which may be mistakenly diagnosed as thyroid cyst. There may be focal thyroiditis, or it may be a tubercular or a sarcoidosis. Sometimes parathyroid cysts may present as a thyroid nodule, and I've seen this in my practice, and I'm sure others have also seen that. And very rarely, a rhengoscele may present as a thyroid nodule. So it's good to remember this list. You may not remember the entire list, but it's good to remember the neoplastic and non-neoplastic causes of thyroid nodules. Now, important thing is that what we need to arrive at those two diagnoses, whether malignant or toxic. One is a good clinical examination and history taking. Then second is the evaluation by TSH and ultrasound and some other investigations. Third is the assessment with the help of cytology, and then involves the management. So it's a kind of stepwise approach, which is not linear. You must keep that in mind. I'll come to that later in my presentation. So as I said, most important is for the clinician and the patient is, does this thyroid nodule harbor cancer? Is this thyroid nodule overactive? And does the patient have symptoms from the thyroid enlargement? And all this can be evaluated with the help of an ultrasound, the TSH, and some other investigations, maybe CT neck. And then we move on to the categorization as assessment of the malignancy. So a couple of slides just to show physical examination. You must remember that the physical examination has low specificity and sensitivity, and the patient may have nodules in 50% cases, which are undetectable. There are various methods of examination. The commonest, and this is for the postgraduates, from the front, which is the Leyes method. Use your thumb to palpate the lobe and ask the patient to deglutate, and the nodule will strike the pulp of your thumb. Coccus sign is important in a large thyroid nodule with incipient compression of trachea. But be careful, a thyroid cyst may feel firm. So a thyroid cyst is always mentioned as a firm thyroid nodule. One time, because of calcification, a thyroid nodule may be hard. So hard nodule is not always malignant. Always comment on the mobility. It may be freely mobile. It have a restricted mobility by virtue of size. I'm talking of these benign nodules. But when it becomes fixed, it's obviously malignant. Always palpate the trachea to see whether it's deviated or not. Very important, if you have a lymph node present, which may be large lymph node and the actual thyroid nodule may be very small or even absent in cases of an occult malignancy, that is an ominous sign. Sometimes it's too big like this. This is not a goiter, but a thyroid nodule of the right lobe. It was actually a thyroid cyst. Family history is very important. This young girl presented to us with the family history. Her mother, her father and a grandmother both had medullary thyroid cancer, and her two siblings ultimately turned out to be medullary thyroid cancer. Both of them underwent prophylactic total thyroidectomy. This is a very important slide for the postgraduates. The clinical findings help you to, these are kind of red flag findings, whether it's highly suspicious based on these symptoms, especially a paralysis of vocal cords, fixation, rapid tumor growth, and a family history of medullary thyroid cancer, as I mentioned, and a moderate suspicions of extremes of ages. If you have a nodule in a young child or an elderly, then you should be suspicious. Male sex, history of irradiation is not so common. And a nodule which is more than 4 centimeters, which is partially cystic, there is almost a 20% risk of malignancy. So any nodule which is more than 4 centimeters, be very careful. And of course, if there are symptoms of compression like dysphagia, dyspnea, and hoarseness, again, they are ominous signs indicating presence of malignancy. We have already had a good discussion in the duologue. Just want to repeat that thyroid ultrasound, actually, you should look for the high-risk features. And the thyroid system combines these features and give you a good pre-test probability whether the nodule is likely to harbor malignancy or not. So these high-risk features, most important are these. I'll show you some photographs. For example, the ultrasound may pick up patient presented with a large nodule, but the ultrasound picked up a few nodules in the opposite lobe. So this was a dominant nodule. This is a benign adenoma, regular margins. Echogenicity is normal, not very vascular. But look at this. There's a large intranodular vascularity, and this was suggestive of a papillary carcinoma. Now, this lady, you can see, had an irregular borders. You see, these are all irregular borders, and this was a case of papillary carcinoma. This lady, again, shows macrocalcification. I hope you can appreciate these macrocals. These are suggestive of PTC. Again, this whole thyroid was full of macrocalcification. So whenever you get these kind of a picture, we show that it's likely to be malignant. If you get a cystic lymph node, then it is likely to be 100% is going to be papillary thyroid cancer. Cystic lymph node is a very short sign for a papillary thyroid cancer in the thyroid. I'll just one slide for the elastography. This is a good technique. Software is there in the ultrasound. We can do it in the outpatient clinic, both the endocrinologist and the endocrine surgeon themselves. And you have some areas which are blue and some areas which are green. So these blue areas are hard areas, and hard is suggestive of a malignant nodule. So elastography can complement your ultrasound diagnosis, predicting malignancy. CT may be required. This was a lady who presented with a large thyroid nodule which was fixed, restricted mobility, in fact, and you can appreciate the CT showed there is blurring of the line between the strap muscles and the thyroid nodule. And this was the appearance of, you can see how ugly looking thyroid nodule is, not a smooth surface. These excrescences or the nodules on the surface, they were infiltrating the strap muscles. So CT will give you an idea about the local invasion and what you should expect during surgery. Now, this is the most important slide, which all the postgraduates and caregivers of thyroid nodules should keep in mind. This is the most standard system of reporting on cytology, with Bethesda 1, which is non-diagnostic, 2 is benign, 3, 4, and 5 are indeterminate cytology, and 6 is, of course, a confirmed malignancy. And we'll be talking more about this 3, 4, and 5 categories. So remember, 2 is benign, 3, 4, and 5 are indeterminate, and 6 is malignant. So just remember these 3 categories, broad categories. So what should be the therapeutic approach once you are faced with a thyroid nodule? It's a very important point to remember that our approach will be based on the cytology result in conjunction with the clinical findings and ultrasound. So these 3 things are very important: cytology, the clinical features, and the ultrasound findings. Now, this is again a slide that we all should remember. This is from the ATA guidelines published in 2016. So whenever you are faced with a thyroid nodule, you have a TSH, which is normal. First investigation to do is a thyroid sonography. And then you categorize whether it's a high suspicious nodule, an intermediate suspicion, or it's a benign pattern. So if you have a benign pattern, then maybe if it's smaller, then FNA is not required. Whereas if it's highly suspicious, even if the nodule is more than 1 centimeters, then you have to do a cytology. But if it is low suspicious, then you have to do cytology only when it is more than 1.5 centimeters. And if it is very low suspicion pattern, only 2 centimeter and more nodules should be aspirated. So the ultrasound guides you in 2 ways. It tells you the pretest probability of malignancy, and it also helps you to stratify which nodules need to be aspirated. Now, once the cytology is available to us, as I mentioned, it may be a non-diagnostic, then you have to repeat the FNAC. If it is benign, no surgery is required, and I will talk in a greater detail in my subsequent slides. And when you have the indeterminate cytology, there are certain recommendations. And if it is malignant, of course, surgery is required. So the difficult group is the indeterminate group, which is the plus group, the follicular neoplasm group, and the suspicious for malignancy group. Now, what is the natural history of thyroid nodule? It's very poorly understood, but you should remember that majority of these nodules, some of these nodules will actually grow by at least 20%, and some are likely to become hyperfunction. And when do you define the growth in the nodule? When there's a 20% increase in nodule diameter with a minimum increase in 2 or more dimensions of at least 2 millimeters. So one must remember that those nodules which are benign. So now I'm going to talk about what to do with the benign nodules, which are Bethesda 2 category. Remember that only 15% on a 5-year follow-up will show some growth in change. So this is very interesting. This is known as alluvial diagram. And if you just concentrate here, you have this class Bethesda 2. And only 15% out of these over 5 years will show some change in the nodule size, which I told you it's mentioned by more than 2 millimeter increase in 2 dimensions or overall increase in 50% volume. Only 50% will increase, and these would require a repeat biopsy. Whereas majority, 75 to 85%, will show no change in follow-up. So if you have a Bethesda 2 category and they are not symptomatic, you can follow up these without any surgical treatment. Again, this is a very nice algorithm. As I mentioned, when you have an ultrasound and you have a highly suspicious sonographic pattern, this is all about Bethesda 2. I'm just talking about Bethesda 2. So if you have a Bethesda 2, but the ultrasound is highly suspicious, there is a 20% malignancy rate in these nodules. So you have to combine the cytology with the ultrasound findings. So in a Bethesda 2, if you have a highly suspicious sonography, you have to repeat the FNAC within 12 months. On the other hand, if there is a very low suspicion, then you can repeat the ultrasound in 12 to 24 months. That is 1 to 2 years. There is no need to repeat annually as you would do in a highly suspicious. And out of these, if there is some change, and a change means 20% increase in 2 dimensions with a minimum increase of 2 millimeters, or they increase in more than 50% volume, then you have to repeat the FNAC. And if the second FNAC is also negative, there is no chance that the patient will develop malignancy. So if you have 2 benign cytology results, no need for further cytology, and only you can repeat the ultrasound if there is to see the growth or see the change, but there is no way, virtually nil risk of this patient developing a malignancy. So this is what is about the Bethesda 2 and how to follow up the, at what interval you should do the ultrasound. The non-malignant thyroid nodules, there may be sometimes because of the compression or if the size is increases, then you have to do surgery for these patients. And the advantage is that is complete relief of symptoms, and you have a definite histological diagnosis available to you. Now, what about the indeterminate group? As I mentioned, that is the 3, 4, and 5. The predictors of malignancy is one is the ultrasound, which I mentioned. And this is a very important figure. In cytology, in the indeterminate group, the pre-test probability of malignancy in a FLUS is 14%. In a follicular neoplasm is 27%. and in suspicious for cytology is 54. How can we increase the pre-test probability? Is by adding the rule-in test or the mutations like BRAF, RAS, RET, and PAX. And you can see the pre-test probability after mutation testing increases to 88% in FLUS, 87% in follicular neoplasm, and 95% in the suspicious, that is Bethesda 5. So addition of a molecular test to an indeterminate cytology really improves the pre-test probability of malignancy, and you can counsel the patient very nicely. So for nodules with the FLUS cytology, and after considering worrisome clinical sonographic features, then, and if you have molecular testing available, then you can discuss with the patient and go ahead and perform a diagnostic hemithyroidectomy. And if the repeat FNA cytology are not performed, then again, depending on the risk factors and the sonographic pattern and patient preference, you can do a hemithyroidectomy. For the Bethesda 4, again, the same thing. If molecular testing is available, it increases your pretest mobility, you can do a diagnostic thyroidectomy. For suspicious group, that is Bethesda 5, again, it is guided by the clinical risk factors, the sonographic features, and you can go ahead and do a diagnostic hemithyroidectomy. So indeterminate group, it is better to do a hemithyroidectomy. And if molecular tests are positive, you can even do a total thyroidectomy. So molecular features, the ultrasound features, and the clinical features all guide the extent of surgery. If BRAF is positive, you will do a total thyroidectomy because this patient has a highest chance of having a papillary thyroid cancer. If the Bethesda is 6, then you do risk assessment. If it is low risk, you can do a hemithyroidectomy. If it is a high risk, then you do a total thyroidectomy. Again, based on risk factor, you can give radioiodine therapy and a thyroid hormone suppressive therapy based on the risk factor of the patient. Surgery should be performed by an experienced thyroid or endocrine surgeons in a multidisciplinary team who have been trained specifically in thyroid cancer surgery and who are performing a large number of thyroid cases annually, including primary or reoperative cases. A word about thyroid surgery. In 19th century, thyroid surgery was carrying a mortality of 40%, so much so that it was banned across the Atlantic, both in the US and the Europe, considering as horrid butchery. But there has been modern innovations and development, and now modern surgery consists of a sutureless surgery where hemostasis is fantastic. The hypocalcemia can be predicted based on intraoperative PTH done at the time of surgery. You can identify the parathyroids with the help of the ICG dye, and you can see whether it is vascularized or not. And you can use neuromonitoring for the stimulating the recurrent angina nerve. And I must tell you that recurrent angina palsy ranks among the leading reasons for medical litigation for the surgeons because it reduces the quality of life. And therefore, this neuromonitoring, especially in high-risk patients like locally advanced cancers, or you can prevent a bilateral injury in these patients. So this is a device that can be used for these patients. Sorry, the figures. Anyway. Last but not the least, large development has taken place for thyroid surgeons to avoid these kind of ghastly scars. Sometimes it happens by surgeons who have not been trained in thyroid surgery. And for these, the remote access robotic procedures have been developed. This lady had a thyroid nodule. I performed the robotic breast and axilla approach, and you can see the breast scars and the axilla scars are hardly visible, and there is no scar in the neck. Another lady with a thyroid nodule, we performed transoral surgery. We went through the vestibule of the mouth, and you can see there is no scar in the neck or anywhere in the body. So it's kind of a scarless surgery, except for a small scar near the axilla for removing the specimen. So it is a totally scarless surgery, and there is no compromise of safety in experienced hands. A couple of slides for the elderly people. If the elderly present with nodules, these patients have poorer health status and comorbidities, and they have a higher risk for treatment complications. So therefore, one must take a personalized decision based on clinical nodule characteristics, the patient's context, and what is the goal of care. So most of these elderly patients with nodules may not require surgery. And for these, especially some non-surgical modalities have come up, such as percutaneous ethanol injections, radiofrequency ablation, laser ablation, microwave ablation, and a very important modality is high-intensity focused ultrasound. I've had some experience with this technique, and it works very well for the nodules in patients who have very frail and who cannot be operated because they're high anesthetic risk because of comorbidities. So as surgeons and as endocrinologists, we must be well versed with these non-surgical modalities and can use them as the situation demands. So, ladies and gentlemen, I'd like to conclude by saying that recent innovations have facilitated newer approaches like the Scarless approach, the robotic thyroidectomy. We have a lot of technology which helps in hemostasis, and we can predict hypocalcemia. The neuromonitoring can help identifying the nerve and prevent the dreaded recurrent engine of palsy or hoarseness in the patient. And important thing is that it's not a one-size-fit proposition for these patients. We have to take a personalized view for these patients. We must remember that very few nodules will require intensive work. That would include cytology and molecular testing and elastography. And the goal is to identify the best strategy for the patient in terms of disease outcomes and quality of life. And therefore, we should avoid the pitfall of overdiagnosis and overtreatment. And for health professionals like us, this means learning to work with some degree of clinical uncertainty rather than automatically resorting to intensive testing and intervention. And we must weigh the patient's expectations and its or her demands that are at that point of time. So we should approach it, we should rather, have a non-linear approach. It means that our decisions should be based on an intellectual sense, that is based on clinical evidence, on the practical sense, that is they are feasible and appropriate for the patient to do, and they should have an emotional component, whether we feel like the right thing to do for the right reason. So it's kind of a non-linear approach. We have to take the clinical features, the thyroid ultrasound assessment, the FNA results, repeat thyroid FNAC when is required. It's very important to have an expert second opinion cytology, and when required, molecular markers can help you improve the pre-test probability of malignancy in the thyroid nodule. Now, before I end, I'd like to leave you with this slide. Our ancient thyroid surgeons and physicians, this is from Shushruta Samhita, and you can see they mentioned that the patient of goiter who breathes with difficulty, whose whole body has become flaccid, whose disease has lasted more than a year, who has anorexia, is emaciated, and has hoarseness of voice should be discarded from treatment by the clinician. Thank you, ladies and gentlemen. I hope I was able to give you a broad overview of the nodules which do not require surgical management.
Excellent. I really enjoyed that. Thank you, Amit.
Thank you, Dr.
so much. Over to you, Dr. Naik.
Thank you, Amit sir, for such a wonderful presentation on clinical approach and modern aspect of the management of thyroid nodules, and also the role of molecular aspect in intermediate nodules. Also, the personalizing the treatment in patient with thyroid nodules.
Thank you.
Once again, thanks, Amit sir, for such a wonderful talk.
Just one question in the question.
Yes.
If you can take that about laser ablation and ethanol ablation.
Yes.
If Amit can just throw, he has told in his talk, but little bit if he can tell about that.
See,
They're
ethanol
asking
ablation,
when it is done in India.
Yes. I mean, it's a simple procedures can be done in any center, but you must remember if the ethanol leaks, it may cause hoarseness because of damaging the recurrent angina. So these procedures are not absolutely 100% safe, and one has to get used to these procedures. For example, HIFU and laser, if you carefully use it in specific situations, they are wonderful tools. And I think every physician, every surgeon should have be well versed in these kind of techniques.
Thank you, sir. So, shall we move on to the next? This for the explanation.
Yeah.
Thank you, sir. Thank you very much. Thank you.
Winners now. Yeah.
Yes, I'll request Dr. Gaganpriya madam to discuss the answers, and at the end we'll be announcing winners.
Yeah. Thank you so much. I think another very interesting topic has been discussed. So we'll quickly go through the answers in the next 3 or 4 minutes, and we'll have the results at the end. So the first question was about the salt iodization program, and this is the seminal work done by the group of, which started with Professor S.S. Sooj, and then when Dr. Ramalingaswamy and Professor Kochupille. So all of the have pioneered the Kangra Valley program, wherein they divided villages into 3 groups and looked at the role of salt iodization. And in fact, this is internationally the first salt iodization program, and India was the first country to launch the National Goiter Control Program. Now, how is this related to thyroid? What you can see is the classical orphan Annie I nuclei that we know are described in papillary thyroid cancer. Very interestingly, this was a daily comic strip that went on for almost more than half a decade, and it was Dr. Nancy Warner who described these tumor cells with empty nuclei and a thin rim of peripheral chromatin. Before the availability of thyroid hormone assays, the first parameter which was clinically used, of course, all of them have been used in their own way, all of these 4 options, but basal metabolic rate was the first parameter being used till we have serum protein bound iodine, which became a more systematic way of actually assessing response. And thereafter, of course, thyroid hormone assays came in. Now, in patients with hypothyroidism, polymorphism of the type 2 deiodinase gene is the one wherein this particular polymorphism, threonine 92 alanine polymorphism, has been described, the carriers of which are likely to benefit from addition of T3 therapy. This enzyme converts T4 to T3. The 5th question was a lady with Graves' disease who was on carbimazole, but then started complaining of GI symptoms, dehydration, hypotension. Type 1 diabetes, unlikely because the potassium was high. Normally, initially phase, you'll have hypokalemia again, and gastroenteritis would not cause this kind of dyselectrolytemia, and she doesn't have a history of fever or anything else. We don't see such drug intolerance with carbimazole at the end of 1 month. So most likely is adrenal insufficiency as an autoimmune syndrome. Which of the following is incorrect? The first 3 options were actually correct. Option D, that free T4 when measured by commercially available immunoassays is not more reliable than total T4. And in fact, that's why most thyroid associations now recommend that unless you're doing free T4 by equilibrium dialysis, you should, with the commercial assays, you should actually look at total T4 values. And for pregnancy, you can multiply that value. 2nd trimester onwards, you can multiply that total T4 by 1.5 to get the pregnancy reference range. This case, which had a patient who had multiple small papillomas and intestinal lymphoid polyps with a follicular neoplasm of thyroid and a family history of FTC, is a case of autosomal dominant Cowden syndrome, wherein these multiple papillomas called trichomonas are very classical lesions. They can be associated with breast and thyroid cancers, but it is the hematomas which clearly stand out in this patient. The other possible differentials, familial adenomatous polyposis, also autosomal dominant, comes with these colonic polyps, but very typical are desmoid tumors and a hypertrophy of the retinal pigment epithelium. Gardner syndrome is a variety of FAP. Again, the most typical differentiating feature would be epidermoid cysts and osteomas or dental abnormalities. And of course, we all know Carney's complex is associated with that typical Cushing syndrome with PPNAD, cardiac and skin myxomas, lentigenes, blue nevi, etc. And all of these can have tumors of the thyroid. Now, this sign is the Geoffroy sign, lack of wrinkling seen on the forehead in a patient with thyrotoxicosis, and the other signs, PBS is the lack of convergence. D'Alembert sign is the lid retraction you can see in a patient with the word thyrotoxicosis, and lid lag is the von Graffe sign. Our patient, 65-year lady who had anxiety, she had subclinical thyrotoxicosis. So we have an elderly lady with subclinical thyrotoxicosis and osteoporosis. And we know that subclinical thyrotoxicosis with the TSH of this low in such a woman should be investigated further. So the best thing to do for her is not active surveillance, but go for thyroid scintigraphy, make a diagnosis. This was in fact a real case of mine. She turned out to have Graves' disease. Next patient was a 45-year male diagnosed with Graves' disease, put on carbimazole, and he had hypoglycemia soon after in a month's time with high serum insulin and C-peptide. Possibilities, unlikely APS because we are seeing hyperinsulinemia here. Insulinoma, this kind of a presentation is unlikely. Surreptitious sulfonylurea intake can be ruled out because the C-peptide is high. So this is endogenous hyperinsulinemia. So the most likely diagnosis here is autoimmune hypoglycemia triggered by carbimazole. We know carbimazole, like drugs, have sulfhydryl group and they can trigger the formation of autoinsulin antibodies. So Hirata syndrome. What is Mieseberger triad? This was described by Basedow. Tachycardia, exophthalmos, goiter. In fact, there is no person by the name of Mieseberg-Chekhov. It is Leon Chekhov who described the Wolff-Chekhov effect along with Jan Wolff. And why the name Mieseberger? Because that's the place that von Basedow comes from in Germany, Mieseberger. 36-year lady with thyrotoxic symptoms, past history of long-standing hypothyroidism, another real case of mine. She Struma ovari, we'd already ruled out because the ultrasound abdomen and pelvis normal. Painless thyroiditis won't last this long, 2 to 3 months of history. Graves' disease is unlikely. We've already done a technetium scan. So it's not blocking antibodies turning into stimulating antibodies. This was a case of ectasious thyrotoxicosis. The woman was taking methimazole, but also was taking 4 to 5 tablets of thyroxine on her own without anybody knowing. Now, what is the cutoff for TSH in congenital screening? In both cord blood and postnatal sample, in serum units, it's more than 20 milliunits. We have to remember that if dried blood spots are being reported, they can sometimes be reported in whole blood units, wherein you have to convert whole blood unit to multiplying 2.2 to get a serum unit value. And this is the cutoff recommended. Now, which of the following drugs is not useful in management of thyrotoxicosis? We have cholestyramine. It's an ion exchange resin. It interferes with the enterohepatic recycling or reabsorption of thyroid hormones. So it can be used in symptomatic hyperthyroidism. Lithium interferes with iodine uptake in thyroid. Dexamethasone, it interferes with the conversion of T3 to T4, T4 to T3. So all three have been used in thyrotoxicosis management, and colchicine is not used. FNSE from thyroid, this is a classical Samoma body, which has been described as a textbook picture of Samoma bodies, spherical calcified foci with concentric laminations. The last question was abnormal TFTs, no symptoms. So you had a low T3, T4 and TSH normal in an asymptomatic patient. The first thing you should think of is a deficiency of TBG, which can cause a falsely low total T4 and total T3. And if you measure free T3, free T4, they will be normal. So I'll conclude here. And I think we have the winners. So maybe
I request Dr. Sarita Bajaj Madam to announce the winners.
So the winners for today are Iram Nahid and Sagar Saurabh, who are at 13 points each.
Great.
Afsar, Ziban Pradhan and Parth Jetwani at 12 points each. Congratulations to all 5 of you.
Yeah,
Well done.
I request
But
the winners.
I think most of the names are complete.
Yes.
Because that's what Gagan had requested in the very beginning itself.
Yes.
Thank you, Gagan.
The winners can please post their email ID so that the certificates can be sent to them. That will be easy for us then, because if we have the email IDs, we'll know who are there, so we can send the certificates to them.
Yeah, so our certificates are ready, and we'll be posting even the last week's quiz. So now it will be on a regular basis. You'll get your certificates as soon as the quiz is over. At least within 24 hours, I hope. Thank you. Thank you.
The attendees have now been given rights to open the chat and type your messages. So I request you all to please put in your email IDs in the chat. The winners, the quiz winners, please.
I request Dr. Pramila Kalra ma'am to give the concluding remarks.
Madam, Sarita Bajaj Madam will give the concluding remarks, and Dr. Mini, because Dr. Mini is the moderator for today. So I hand over to Dr. Mini to conclude the session for today.
Thank you. Thank you to all our faculty. I think they've done an excellent job, from Vagish and Satinath to Gagan to Amit, and of course our conveners, Mini, Pramila, I think Arun was not able to join us, so he said he would be able to. Congratulations to all the winners. Over to you, Minnie.
Yes, ma'am. Thank you. And first of all, I thank Dr. Naik, who has chaired the session very efficiently, and we have finished almost on time. And I thank Dr. Vagesh Iyer and Dr. Mukhopadhyaya, who has conducted a very lively, interactive dialogue, and we have learned a lot from them. I thank Dr. Gagan Priya, very lively and very nice quiz. And last but not the least, Dr. Amit Agarwal, as precise and clear-cut as always, crisp presentation. Thank you very much, sir. And I thank Dr. Pramila Kalra, who has done all the work behind this. Of course, our president, Sarda Bajaj Madam, whose idea is this whole weekly sessions is actually her brainchild. So thank you very much. And of course, all the delegates. I thank all the delegates for the participation, and also our digital team, who has been very efficiently organizing these sessions. So thank you all very much.
Thank you so much, ma'am.
What about the next week's meeting? So next week we have 2 journal clubs, and that is from Jodhpur, the Department of Endocrinology. And we also have a talk from Nuclear Medicine, SGPGI, Lucknow, by Dr. Amitabh Arya. So we have a very, very interesting session. That will be the 3rd in the series of our thyroid clinics. Thank you, Minnie. Thank you, Pramila.
Thank you, ma'am.
Saurabh.
Thank you, Dr. Naik.
Thank you, ma'am. Thank you, ma'am.
Thank you, Dr. Naik, for chairing. Thank you so much for joining us.
Thank you, ma'am. Thank you.
Good night,
Dr.
everyone.
Sagar Saurabh, if you are still available, please put in your mail ID. Dr. Sagar Saurabh.
Thank
Do we
you.
have the mail IDs for the last time winners?
No, ma'am, we don't mail IDs for the last time winners.
Because 2 of them are our residents only. So I know those 2, they will send. The others,
Okay, ma'am.
I'm not sure, but the 2 of them are our residents. And the other 4, you can just send me the names. I'll tell them, because they have the residence group, so they can find out if they know any of them.
Yes,
At
ma'am.
least
Pramila, are you comfortable with the design of the certificate? I think so long as it's
last time, ma'am, that certificate I